Hello, everyone. Welcome to today's webinar. I have Marcus and I have Dr. Richard Marshall. How are both of you guys doing today?
Doing well. Thank you.
Very well.
Awesome. Really excited for today's webinar. But before we get started, Marcus, do you want to give a little bit background of yourself and the purpose of today's webinar?
Yeah, so my name is Marcus Elliott. I am I'm VP of R&D at Everin Technologies. So day to day, we're working on our medical device development here. And I was the one that, in conjunction with Dr. Marshall, ran our original pilot trial in VNS for the treatment of PTSD. So we worked together on that. And so today we're going to talk a little bit about PTSD. We're going to talk some about trauma, and then hopefully we'll talk a little bit about our pilot trial and what happened in that and VNS mechanisms.
Yeah, thank you for that. And then Dr. Richard Marshall, if you want to give a little background about yourself.
Right. I have most recently, I have a doctorate in neuropsychology, and I have a particular interest in these topics of PTSD, trauma, brain function. And so when I was approached by Marcus initially to participate in this project, I was really enthused because I knew the theoretical background to this device. I had studied it and knew about it, had never seen one or used one. So I was really excited to be part of the pilot project. This is an exciting line of research for all of us clinicians. And I have 3 groups of patients with PTSD now that I work with. And I just can't tell you how enthused I am about being able to use a device like this with them. So I'm happy to be part of it. Thank you.
Awesome. Awesome. And I do want to remind everyone that Everin is running a equity crowdfunding campaign on Start Engine. I will add the Start Engine link into the chat box below. There it is. Open up. Sorry. Okay. For some reason, I thought I had it and then I lost it. So here it is in the box below. But yeah, so this is, a really great webinar. Excited to hear a little bit more about trauma and the brain function. With that being said, let's get down to it. Dr. Marshall, the floor is yours.
Okay, thank you. We're going to talk about trauma and PTSD as it relates to brain function, because what we need to understand after this webinar, what we need to understand is that trauma has a specific effect on the brain, and we need to understand that in order to understand this device, how it works, and the promise that it holds. So we're going to begin with talking about trauma, and trauma leads to stress. Stress is, of course, what the word is used for whenever an organism is under stress. It produces the fight or flight response. It also produces defensive aggression. Stress, in turn, creates PTSD. If the stressor is significant enough, intense enough, long enough duration, stress will create PTSD. And what we need to understand about PTSD is, what are the diagnostic characteristics? PTSD is a very specific diagnosis in DSM-5, and we need to understand and meet the criteria in order to make the diagnosis. Making the diagnosis of PTSD leads to the last step in this process, which is, what are the brain changes that are brought about by PTSD? And there are both structural and chemical changes that occur in the brain of people who have experienced significant trauma, stress, and end up with a diagnosis of PTSD. Now, trauma has been defined by the American Psychological Association. And essentially, I won't read these definitions to you, but it's a disturbing experience that results in significant fear, feelings of hopelessness, and dissociation. And the reason dissociation is in a different color ink is because this term is not well understood. But this is the term that we use for flashbacks and memories of the event. And sometimes the memories are so stark and so intense that the person actually feels like they're going through the experience again. And that's dissociation, because you're dissociating from real life and you're brought back to the traumatic experience. We see this especially in veterans, military veterans, who re-experience the trauma of battle. Frequently they do it in dreams, sometimes they do it while awake. So dissociation is an important part of this because of the flashbacks and memories. But these are intense reactions, and they will change. The event can be caused by human behavior, such as sexual assault, war, industrial accidents like Chernobyl, as well as natural events like earthquakes, hurricanes, and tornadoes. And so what these events do is they challenge the person's feeling that the world is safe. They begin to feel unsafe in the world that they're living in. In order to make a diagnosis of PTSD, we use what is called the Diagnostic and Statistical Manual of Mental Disorders. In the United States, this is the book that we use to make diagnoses. And in 2013, the 5th edition of the manual was published. This year, it has been revised. So there is a text revision of the Diagnostic and Statistical Manual. It came out a couple of weeks ago. But the new diagnosis now that we're using is a category of disorders called trauma and stressor-related disorders. And if you look at that list on the right, you see a list that ends with PTSD. PTSD is one of the trauma and stressor-related disorders. And I'm not going to discuss all of the others except one, and that's the third one, which is acute stress disorder. Acute stress disorder is like PTSD, but it lasts for only about a month. So if you were in a car accident, my daughter was in a car accident in February. She had acute stress disorder for about 2 or 3 weeks after the accident. Those symptoms have disappeared. If they don't disappear and they go on, they continue on, then you move into the category of post-traumatic stress disorder. Now, when we talk about PTSD, the diagnosis, we have to talk about 4 things. One is there has to be a significant stressor. Again, it can be man-made, natural, but we have to talk about, first of all, there's a stressor. And then there are 4 categories of problems, of difficulties. One is intrusion, one is avoidance, negative changes, and a different difference in arousal and reactivity. And what we're going to look for are, we want to find the 20 symptoms that define PTSD. And when we talk about a stressor, the stressor can be direct, it happened to us. It can be something we witnessed. It can be even something we learned about from somebody else. The intrusion, when we talk about intrusion, here we're talking about memories and nightmares and flashbacks. And the reason there's a numeral there, that number 1, you have to have 1 intrusive symptom. You have to have at least 1, okay? You might have more than that, but you have to have at least 1. Second is avoidance. This is avoidance of thoughts, of people, of behaviors, of situations. Anything, when you work with people with PTSD, they assiduously avoid anything that might remind them of the event. People might remind them, being in certain situations might remind them, certain thoughts might remind them. But again, you have to have at least 1 of these symptoms. Then you have to have negative thoughts and mood. These are things like shame, fear. Fear is the biggest. Other people blame themselves. Frequently, people who are victims of assault, even if it's not their fault, they have some self-recrimination, some self-blame. And here you have to have 2 of those symptoms. And then the third is altered arousal and reactivity. This is irritability, vigilance, a very delicate startle response that is triggered very quickly. You often hear people say that a family member will come up and tap them on the shoulder, and it creates a startle response because people become hypervigilant because of that arousal. Then the other three things you need is you need duration. It has to last for more than 1 month. There has to be functional impairment. What is functional impairment? In order to make a diagnosis today, you might meet criteria for a diagnosis, but if you don't have functional impairment, we don't make a diagnosis. So there always has to be some functional impairment. Now with PTSD, functional impairment is almost a given because of the 4 categories of symptoms that we just talked about above. So functional impairment is not unusual. And then finally, you have to exclude any other cause, such as medication effects, substance use and abuse, or some other illness. So there are very specific criteria that have to be met in order to make a diagnosis of PTSD. So once we've made the diagnosis, now we can talk about the neurobiology of PTSD. And I put this PET scan here because PTSD can be caused by something that happens to you, but in this case, it's caused by something that didn't happen. And in this case, you see the brain scan, and if you think, you can see the front and back of this brain. And what you're doing is you're looking at the top of the brain. So you're looking down onto the top of the brain, about halfway through. And so this is a slice of the brain. And you see on the left, you have a healthy brain. And you see those areas that are circled in red. That means there are neurons there, and they're active and they're working. Now on the right, you have a brain of this person wasn't abused. This person was neglected. This is a child who grew up in an orphanage, was neglected. And those parts of her brain simply didn't become active. The brain wires itself. When you're born with all your neurons. You have 100 billion neurons. You're born with all those. What has to happen over time is those neurons have to connect and become capable of doing things. And how that happens is you are talked to and you're worked with and you have experiences, and all of those things connect the neurons into meaningful, usable networks. And you can see on the right that didn't happen. So those neurons either aren't there, they died off, or they never connected. So the effects are profound, and you can see them. You can actually visualize the effect of PTSD. Now, what we're going to be talking about, and this is the elevator version, the Reader's Digest version of the central nervous system. You need to understand 3 parts of the central nervous system. The first is the central nervous system. The second are the cranial nerves. And the third is the peripheral nervous system. The central nervous system is the brain and the spinal cord. And the peripheral nervous system is everything that happens outside of the brain and spinal cord. The way our bodies work is our brain produces messages that it sends down the spinal cord to go to the rest of your body. So if you want to lift your right arm in the air, your brain sends a message to your right arm and tells it what to do. So the message goes down the central nervous system, then it's transferred to the peripheral nervous system, and it activates that part of the nervous system to create that motion of raising your hand. The third part of this system are the cranial nerves. In addition to the information that goes to the spinal cord, the brain also sends information to and from the face, the head, the neck. And that's done by 12 cranial nerves, and they're numbered 1 through 12 with Roman numerals. And so the reason I'm talking about cranial nerves is because one of them is the 10th cranial nerve, and that's the vagus nerve. So that's why the cranial nerves are important, because one of them is the 10th cranial nerve. And as it turns out, that 10th cranial nerve is called the vagus nerve. Vagus means wander. It wanders through the body. The other cranial nerves stay in the head and neck region. They innervate the eyes and the ears and the tongue. When you go to the dentist and you get a shot of Novocaine, you're getting Novocaine in your 7th cranial nerve. And that deadens that area of your mouth so that the dentist can do his work. So each of those 12 cranial nerves have a very specific job to do. But the 10th cranial nerve leaves the cranium and goes down through the body to affect organs throughout the body, especially the gut and the heart, okay? And then the peripheral nervous system, the third part of this system, is everything that gets transmitted, all the motor information that gets transmitted to the muscles, and all the sensory information coming from your body that goes back up to your brain. So if you pinch yourself on the hand, that creates an electrical impulse that travels up the peripheral nervous system into your brain, and your brain says, oh, you're being hurt, move away, okay? And so remember, the central nervous system is the brain and spinal cord, the cranial nerves here, and the peripheral nervous system, which is everything outside the central, which carries motor information to the body and carries the body's sensory information to the brain. When we talk about the brain, we typically think of this structure right here, and we think of this wrinkled mass of tissue. Well, that wrinkled mass of tissue is only 3 millimeters thick, and 3 millimeters is the diameter of a pencil eraser. Now, it's an important 3 millimeters, but that, in effect, is the top layer of the brain. It is what we call the 5th brain. You have 4 other brains underneath that, okay? So the brain, if you think of the brain as a Japanese house where each generation is on the next story up, okay? So the brain is like that. It starts at the spinal cord, right here, the reptilian brain, and those are your vegetative functions. That's respiration, breathing, all the things that we do automatically. That's in the brainstem. And then you have a second brain and a third brain, but we can skip those. They're not important for our discussion today. And you get to the 4th brain, and the 4th brain, also called the limbic system, is where the emotions reside. So this is the part of the brain that produces or inhibits your emotions. Mainly, it produces emotions. And the job of the 5th brain, the cortex, is to inhibit those emotions. If you didn't have a cortex, if you didn't have a frontal lobe cortex, your emotions would just be spilling out all the time. So the front of the brain contains our emotions so that we're not feral animals. We have the ability to make decisions and to control our impulses. But those impulses come from the limbic system. Now, the important part of the limbic system for our discussion is a structure called the amygdala. And the amygdala is the word amygdala means almond. It's an almond-shaped structure. You have one on each side of your brain. And if you drilled a hole here and here, where they met is about where it's under your eye, near your nose. And the amygdala, its job is to perceive threats. And when it perceives a threat, it sends an electrical impulse to the hypothalamus, and the hypothalamus releases hormones into the pituitary gland. So it's this very regular, routine process of the amygdala perceives a threat, it sends a message to the hypothalamus to release hormones. It releases hormones to the pituitary gland, which then send those hormones to the rest of your body, and those hormones send you into fight or flight. Here's another way of looking at it. So you see something dangerous, and the brain, the eye senses, it sends that message to the back of the brain because vision occurs here. These eyeballs are just like they just let light in. They don't really do anything. The eyes don't see, the brain sees, and the brain sees in the occipital lobe. Well, the thing about danger is that you don't always have time to figure out that something is deadly or dangerous before you have to do something. And in the case of a poisonous snake, or a gunshot, or an explosion, or screeching tires, you react before you know what it is. And the reason that happens is because these visual symbols also go to the limbic system. They go to the amygdala. And if the amygdala perceives a threat, it hears a gunshot, that's a threatening sound. It sees a snake, that's a threatening sight. It sees an arrow coming at your head, that's a threatening sight. You don't have to think about, oh, well, let me see what kind of a snake that is. Let me count its rattles. Let me look at its eyes to see if they're horizontal or vertical. You don't take time to do that cognitive processing. Instead, your amygdala says, get out of the way, you're in danger. And that sends you into fight or flight. So fight or flight happens at a subconscious level, not at a conscious level. So here we see the same picture. We have a dangerous visual experience, goes to the amygdala goes to the hypothalamus sends hormones, and it activates these two yellow things. Okay, they sit right on top of the kidneys, all right? And when those get activated, these are the adrenal glands. And when the adrenal glands get this hormone from the brain, the adrenal glands then release adrenaline. And when they release adrenaline, now you have this hyper aroused state that we call fight or flight. Here again, same kind of picture, just a different diagram. So hormones are sent to the adrenal glands, and the adrenal glands produce cortisol. And cortisol is a hormone, and that's what sends you. Now, the danger here, and the reason I mentioned cortisol, is that while cortisol is needed for the flight or fight response, it's also if cortisol persists, it's not supposed to persist. You know those nature movies where the lion chases the zebras or the wildebeests, and then the lion jumps on one and suffocates it and drops it to the ground? Then all the other zebras stop running, because fight or flight was not meant to last very long. It's a high energy enterprise, and it's not meant to last very long. And in most wild animals, in most feral animals, the fight or flight response only lasts until the danger's over. Humans, however, will persist, and they'll continue the fight or flight response. We have chronic stress, we have chronic anxiety, we have PTSD, and that keeps us in fight or flight. It keeps the cortisol flowing, and cortisol can damage brain tissue. So when we talk about the physiologic effects of PTSD, we're talking about a chemical, cortisol, that actually destroys brain tissue if it stays in the system. So it is a significant finding. Here again, we see a little sharper image of this idea of the brain and spinal cord going to the peripheral nervous system. Now, the reason that's important is because of this picture. The peripheral nervous system, I'm going to go back. The peripheral nervous system does a number of things, but one of the most important functions of the peripheral nervous system is that the parasympathetic nervous system, this part here, the parasympathetic nervous system it activates our bodies so that we can go into fight or flight. So for example, during fight or flight, the pupils dilate. It's like you went to the optometrist, you got drops in your eyes, and you can see everything. They open automatically so that you have a bigger field of vision. Okay, you don't control that; it just happens. Your breathing increases, your heart rate increases. All the things that you need to go into fight or flight are activated in the sympathetic nervous system. So all that stuff, all those body systems get energized, and you go into fight or flight, and you either run or you fight. You can also freeze, and people say, well, why would a person freeze? Well, the reason some people freeze is the reason that field mice freeze. Okay, the hawk is 2 miles in the air, and it sees rustling, it sees a little movement on the ground. And so the mouse knows that if it stays still, it's less likely to be detected by the hawk. Okay? And so freezing, it's what deers do. Fawns will freeze. They'll lie on the grass and they'll freeze, because freezing is a way of surviving. So we retain the freeze mechanism. And sometimes you can get so aroused that you actually freeze. Okay? And that's not abnormal. It's part of the fight or flight response. Now, I said a minute ago that the fight or flight response is not meant to last more than a few minutes, a few seconds, maybe to a few minutes. And then the nervous system has to have the capacity to bring the body back to normal. So that when the sympathetic nervous system is activated, it goes into fight or flight, but immediately after that, the parasympathetic nervous system then returns the system to normal. What does it do? Well, now it constricts the pupil. It brings it back to normal. It stimulates salivation so we can refuel, we can drink and eat. It slows your heart rate. It constricts your bronchi. Your lungs don't have to be filled with air to run, so they go back to normal. It stimulates digestion so that you can restore with food. And it also causes the bladder to contract. All of these things are shut down during fight or flight. You don't want to eat while you're fighting for your life. So the digestive system, the sympathetic nervous system shuts that down. You don't want to go into reproductive activities when you're in fight or flight. So the reproductive system gets shut down. But all that stuff is returned to normal after the threat is gone. And so these two parts of the peripheral nervous system, the sympathetic system, the parasympathetic nervous system, work in concert to activate sympathetic and then return to normal parasympathetic. The reason you return to normal is there might be more than one threat. So you've dealt with one threat, but now you have to gear up, restore, and get ready for a second threat that might be there. So this happens very quickly and for a very adaptive reason. This is a really good diagram of what I just talked about. You have the human nervous system. It's in the top green box, divided into two parts: central nervous system, peripheral nervous system. So the central nervous system, brain and spinal cord; peripheral nervous system, cranial nerves and spinal nerves. We talked about the cranial nerves. We talked about the spinal nerves. The peripheral nervous system is further divided into an autonomic nervous system, and a somatic nervous system. The somatic nervous system controls your voluntary muscles. You're sitting at your desk and you want to reach for the mouse. That's your somatic nervous system. Everything else, the autonomic functions, heart muscles, smooth muscles, all of your internal glands and organs, they're all controlled subconsciously, unconsciously by the autonomic nervous system. The autonomic nervous system also controls the parasympathetic and sympathetic division. So sympathetic is active and alert, parasympathetic is regroup, restore, lock and load, get ready for it again. So it's rest and digest. So this is I think, a very helpful schematic diagram of the human nervous system. What we're interested in are the last two parts, the parasympathetic and the sympathetic. That's where we have to focus our attention for the rest of this webinar, okay? So again, this is what it looks like, and we're going to focus on parasympathetic and sympathetic. Now, as it turns out, the 10th cranial nerve, remember the cranial nerve is part of the part of the peripheral system. The 10th cranial nerve activates the sympathetic and parasympathetic nervous system. We've known that for, I don't know, at least 100 years. We've known that the vagus nerve innervates all these other parts of the nervous system. So remember I said there were 5 brains, and the first brain starts at the spinal cord. There's a space between the spinal cord and the brain. The second and third brains, I said, well, they're not important for what we're talking about. That's where most of the cranial nerves come out of. They come out of the second and third brains. And so they do have a function, but it's not really necessary for our discussion. Okay. So the 10th cranial nerve, this vagus nerve, comes out of the lower part of the brain, and it goes wandering through the body. And as it wanders through the body, it branches off and does different things. So this is a drawing that shows you how complex the vagus nerve is. And so you see it exiting the lower part of the brain, and then you see these branches. Okay, so here's the vagus nerve. It's a big thing. You can see it. I mean, you can open up if if you did surgery, you open up somebody's neck, and it's easy. You don't need a magnifying glass to see it. You can see the vagus nerve, and it's right beside the carotid artery, which is also a problem, but that's another story. But what you see here is these are all the branches of the cranial nerve, and each branch has a distinct function. So each of the branches of the vagus nerve controls a body function, including digestion, heart rate, breathing, reflexes like coughing and sneezing and gagging, swallowing. You've heard of the not the butt-brain connection. You've heard of the gut-brain connection. That's controlled by the vagus nerve. That we all know about gut-brain. And it also controls the autonomic nervous system. If you were a neurologist, if you go to a neurologist, one of the things the neurologist will do is they will test each of those cranial nerves. So one of them is olfaction. One of the cranial nerves controls our sense of smell. So guess what we do? We see if they can smell stuff, all right? Others control our eyes, eye movements. And so different parts of the vagus nerve have different functions. The way we test the cranial nerve is to see if you have a gag reflex. See it swallowing, okay, swallowing. So if I want to check to see if your cranial nerve is working, I stick something down your throat, and if you gag, then I know your 10th cranial nerve is working. But you see the most important function is at the bottom. It's the autonomic nervous system, and especially the parasympathetic part of the nervous system. Now, before I go into this vagus nerve stimulation, are there any questions or anything that you want to go over? Because we're really entering a very different part of this discussion now. Is that a no?
Yeah, like Dr. Marshall said, if you have any questions, put them in the chat box below, and we will answer them throughout this webinar.
Okay. And if you get a question and you want me to stop, feel free to interrupt me. Okay, it's not a problem. I think we have plenty of time. So just let me know if you want to pause, you want to stop, or do you want me to address some other issue. That's perfectly okay.
Yeah.
All right, so we now have a fundamental understanding of the nervous system, and we are now going to focus on the parasympathetic part of the nervous system. And now we're going to talk about how we stimulate the vagus nerve to affect the parasympathetic nervous system. Now, the wonderful thing about vagal nerve stimulation is that it is now being used to treat an array of conditions. Since 1988, the vagal nerve stimulation, VNS, has been approved for the treatment of epilepsy. I have a patient now who had intractable seizures as he's a teenager now. I saw him when he was in elementary and middle school, and he had intractable seizures, and nothing ever worked. No medications worked, nothing ever worked, surgery. So he recently was given vagal nerve stimulation, and it was a surgical procedure, and we'll see what that looks like in a minute. But his seizures have finally been brought under control, and for the first time in his life, he's been able to live with other family members. He was completely out of control because he was having 100 or more seizures a day, and he couldn't go to school, and he had violent rage attacks. And now he's able to live at home with his mother, and because of the vagal nerve stimulation procedure that was done. It is also, vagal nerve stimulation is also approved for intractable depression, for depression that can't be treated any other way. Now, for these other conditions like tinnitus, migraine, rheumatoid arthritis, stroke recovery, autism, pain, the ethical decision is, does it warrant an invasive and possibly dangerous side effects of wrapping an electric coil around somebody's vagus nerve? That is a procedure that is not without risk. And so the question that we ask is, is it worth creating irreversible side effects in order to treat a condition like anxiety or PTSD? Now, that would be called, if there was a way to do that, that would be the miracle, okay? So we know that we can surgically implant an electrode, a coil, an electric coil around the vagus nerve, but all that electricity is occurring near the voice box. And so one of the side effects of a surgically implanted electrode is that you can affect a person's vocal cords because all this stuff is together. It's also close to the carotid artery. You don't want to mess with that. So what we've been looking for is a non-invasive way of stimulating the cranial nerve, of stimulating the 10th cranial nerve, so that we can affect change and affect things like depression and anxiety and rheumatoid arthritis, and not have the risks of a surgical procedure. And as it turns out, here's the surgical procedure. So what we do is, you can see this coil gets wrapped around the vagus nerve. You can see, I'm gonna have to put my glasses on for this. So the vagus nerves, the vagus nerve exits the brain. There's one on the left and one on the right. We usually take the one on the left, okay? That's the one that we focus on. And so the vagus nerve, we wrap a coil of electrodes, just like a little coil, around the vagus nerve, and that is connected to a pulse generator, which is usually right under the skin. It's like a pacemaker, okay? Now, for epilepsy patients, patients with epilepsy, we know that by stimulating the vagus nerve, we can send information up into the brain to affect neuronal function. So in the case of epilepsy, we're sending impulses to the brain. With VNS, with vagal nerve stimulation for the parasympathetic nervous system, we're going to send information down to the peripheral nervous system. So it works both ways. So we treat epilepsy by sending pulses to the brain. We treat PTSD by sending pulses down to the peripheral nervous system. And we do that because of a miracle of nature called the outer ear. And as it turns out, we are learning something that acupuncturists have known for a few thousand years, and that is that the outside of the ear, called the pinna, if you stimulate the outside of the ear, you can stimulate the 10th cranial nerve. And so the goal is, if I stimulate this section, this is where the acupuncturists come in. They know all this stuff. We're just catching up to them. This pink section of the ear, this right here, this is the area we're looking at. If we stimulate that, it's called remember I said the vagus nerve has branches? One of those branches is the auricular branch. Auricle means hearing. So the auricular branch activates this part of the outer ear. And if we activate that, we can stimulate. If we stimulate the auricular branch, we stimulate the vagus nerve. That to me is miraculous, okay? Because by putting an electrode here, we can stimulate the 10th cranial nerve, and we don't have to do a surgical procedure. By the way, this is approved in Europe. This is not approved here in the United States. FDA approval is lacking. So when we talk about vagal nerve stimulation affecting the brain, we know, because of epilepsy research, that we can affect all those structures that we talked about earlier that are in the limbic system: the amygdala, the hypothalamus, the hippocampus that makes new memories. And we can also affect the prefrontal cortex. Remember I said it's the frontal lobe of the brain that controls our impulses, that controls our emotions. So we already know, because of epilepsy research, that we can affect all those structures. So with vagal nerve stimulation, with the outer ear stimulation, we know that we can affect both the brain, those emotional structures, and the peripheral nervous system. So in the last part of this, I want to talk about the study that was undertaken, the initial pilot study that was undertaken by Evren, because we wanted to test this system out. If we do this, if we stimulate the outer ear, the pinna, what would be the effect on PTSD? So we know what it does to epilepsy. We know what it does with depression. What does it do with PTSD? So we did a novel take-home prototype of a transcutaneous auricular vagal nerve stimulation. In other words, outside of the skin, in the ear, vagal nerve stimulation. And what was novel about it is that the technology was created by Evren. And so we had a group of patients, and we looked at 12 of that group. And we confirmed their diagnosis of PTSD on this instrument called the PCL. And the PCL actually contains the 20 symptoms of, it's a patient checklist of the 20 symptoms of PTSD. And we let the patient check yes or no, I have this symptom. And if they have enough of the 20 symptoms, then that helps. It doesn't make the diagnosis, it helps to confirm the diagnosis. So we did a 1 month, we did a weekly analysis using that PCL and to help confirm the diagnosis. Yes, indeed, this person really does seem to be suffering from PTSD. In the study, there were 5 women and 7 men. So what we did is we administered the PTSD checklist, that's PCL is PTSD checklist, 5th version, weekly for 4 weeks. After the 4 weeks, we administered an instrument called the clinician administered PTSD scale, which was an interview. It's a structured interview done by a clinician to make sure that the person has the 20 symptoms that they need to meet in order to be diagnosed with PTSD. In addition to that, the PROMIS, which is a quality of life assessment instrument, because in addition to making the diagnosis, we wanted to see if by stimulating the cranial nerve and by using vagal nerve stimulation, could we improve a patient's quality of life? So after we did this initial testing, the participants were given the device and they were taught how to use it, and they would use it twice daily. What does it mean to use twice daily? Well, you hook up the earpiece, it'd be like an AirPod or a little cell phone you put in your ear. And so you hook up the device to a TENS unit, and the TENS unit produces the electrical impulses. So you activate the system and you use it for 30 minutes. You just allow this low amperage, low voltage electricity to activate your outer ear, and that activates the 10th cranial nerve, that activates the vagal nerve. And you do that twice a day for 30 minutes, okay? And then we would check weekly. I think, Marcus, you did those weekly checkups, right? You would check to see that they were using the device, that everything was working properly. After the first month of treatment, so the patient did twice a day for 30 minutes each time, did it for a month, then we re-administered the CAPS-5 and the PROMIS. So we re-interviewed them with the CAPS-5 to see what was happening to their symptoms. Because one of the things that the CAPS-5 does is it tells us of the intensity of their PTSD symptoms. So we wanted to know if the intensity of symptoms reduced after using the device. So we re-administered the CAPS-5. We also administered the quality of life to see if that was changing. And then they did it for a second month. They did the device for a second month, and we re-administered the CAPS-5 and the quality of life questionnaire at the end of the second month. So we were confirming the diagnosis, checking after 1 month of use, and checking quality of life and intensity of symptoms after the second month of use. And what we found many things, but just for the purposes of this webinar, we found that indeed we saw a remarkable decline in symptom intensity because we re-administered the CAPS-5 we did it before the study started, before we gave them the device. We did it after 1 month of use, and we did it after 2 months of use. And we found that the CAPS-5 scores reduced to this level after 2 months of intervention with the device. So on average, and I can say on average, but it was almost 100%, almost everybody who uses the device seems to derive some benefit from it. But again, these are average scores, but they did decline. And these are they're not only statistically significant results, they are also clinically significant results. We saw real changes in quality of life. So we're not talking about just a statistical difference that has an interest to scientists. We're talking about a clinically significant change in quality of life and intensity of PTSD symptoms over just a 2-month trial period. These are the data from the quality of life, and I won't complicate this any more than it needs to be, but I would draw your attention to these are the scores before we use the device. And you can see severe symptoms, moderate symptoms, mild symptoms, and you can see what happens in each category after the device. Quality of life improved over this 2-month period. And you can see for within normal limits, we're not talking about just a gradual or statistically measurable difference. We're talking about a large number of people who were functioning within normal limits after 2 months of treatment. So you see this gradual rise in scores, which means better quality of life after just 2 months of treatment. Now, before we leave here, again, are there any questions or any of this that you want to go over again or that you want to review once again? Any questions from audience or any participants?
Yeah, right now would be the perfect time to ask any questions for whoever is, the audience. Please ask your questions in the chat box below. Let's see, do I have any questions? What symptoms would you see in short-term or long-term with trauma?
What would we see before it's treated?
Yes.
I would go to I would start with this, and they're in 4 categories. Okay, there are 4 categories of symptoms. There are 20 symptoms we're looking for, but they fall into 4 categories, and they are these 4: the intrusive memory, the intrusive thoughts, or the things like frightening memories, nightmares, and flashbacks. So that's the first thing we would look for. The second is avoidance. And when we talk to people, there's a question on the CAPS-5 about, do you avoid certain situations? There are people who don't leave the house. They don't go into public places because they can't control the environment. We see that with veterans. If they can't control their immediate environment, they don't go into malls, for example. They don't go into places where they don't feel safe. They don't go into places where we had one of the veterans who couldn't work in an enclosed space because there was no escape route. And he ended up living on a sailboat. He bought a sailboat and lived on it because he could see the horizon. He could see everything around him. And that was the only place that he really felt safe. He was, of course, armed most of the time, but he was hyper vigilant. And he lived on a boat because he said I could see everything. He had several jobs, and one of his jobs was in a basement, and he lasted a couple of days. And he said, I can't be in a basement because I don't know how to get out of here. He's been here for 15 years. He was in the original Iraq War, and he's still suffering from avoidance behaviors. And then negative thoughts, feelings of worthlessness, shame, guilt. There are soldiers who feel responsible for the death of comrades, commanding officers, or particularly sergeants, the lower level non-commissioned officers who are responsible for a platoon, for a group of men. And if something happens to one of them, they feel responsible, not only because of the death, but to the family of the person who was killed. And then there's altered arousal or reactivity, which is the changes in mood and reactivity, irritability, vigilance, the startle response. We hear stories all the time about veterans who return and become assaultive with family members in their sleep. They'll start having nightmares in their sleep, and they'll attack a family member, usually a spouse or a significant other. So I would look for these kinds of behaviors because these are the cardinal behaviors of PTSD, and they're in full display in most people who have PTSD. The fear, the anxiety, the vigilance, the irritability are on full display in most people with PTSD.
Marcus, is there anything you wanted to add before we wrap up over here?
Yeah, I guess if we just jump to the very end, I think the last quality of life slide, when we talked about the Everin trial briefly.
Right.
Sort of just bring up sort of one of my favorite parts of our Everin trial here.
Okay.
So we made sure to measure, I wish the quality of life assessment was a little easier to talk about, but it's 7 domains for quality of life. So it covers like sleep disturbance, anxiety, depression, social engagement. These are all like really key issues for PTSD. And they're, it shows in the quality of life. I mean, that's the measure of what someone can do day to day. It's a measure of how much they're enjoying their life. Like it's a measure of their ability to be functioning members of society. And we really made sure in our trial that we were measuring quality of life, because a lot of PTSD treatments, a lot of the drugs and other options, they can help people's symptoms, but they don't always actually make their lives better. And so we were really focused on making sure we measured that sort of like, we don't just want PTSD symptoms to go down. Like we want these people to actually function better, be able to live their lives, connect with their families.
Yeah, I'm glad.
So for me, this assessment, like we saw the improvement in that, and that for me is really,
right.
Really.
I'm glad you mentioned that, Marcus, because I think if we continue to talk about these two things, one is a reduction of symptoms. I mean, that's why we use medication. Medications are designed to reduce symptoms so that you can get on with your life, okay? They don't cure the disease, they simply reduce the symptoms. The vagal nerve stimulation reduces the symptoms. But but what we're after is quality of life. I mean, that's where the rubber meets the road, is somebody's life getting better. I can reduce symptoms, but if it doesn't make your life better, would you mind reviewing those 7 areas again, the PROMIS test?
Oh man, ask the hard questions. I know a couple of them off the top of my head. Josh is sitting next to me here. He's pulling them up. I know it's pull up my actual list here.
I'm going to click.
Data and stats. PROMIS 29. Here we go. I think so. Yeah. So the 7 categories. Yeah, we have
anxiety and fear.
Yep, anxiety,
depression. Can you see this?
I'll let you go.
Can you see this?
I'm not sure. Let me, sorry, I was alt tabbed.
I do.
Yeah, anxiety and fear, depression and sadness, fatigue. Yeah.
Sleep, pain, physical function, and social function, right?
Yeah.
And those are the 7. So you studied those repeatedly, you measured those repeatedly, and you got significant changes in all of those after 1 month, but
Yeah.
especially after 2 months.
Yeah, we got statistically significant results overall, and then we got them in the individual categories for all of them except pain interference and physical function.
So what you're saying is you didn't have a noticeable change in pain.
Yeah,
right?
we didn't have a
physical.
statistically significant change in pain. Yeah, I think there was an
Because we
improvement,
weren't-
but it was small.
Right, but we weren't targeting
Yeah.
pain.
We weren't studying a population with chronic pain problems. Yeah.
That's right.
Um,
So we weren't surprised that we didn't see a difference there. And also with physical function, we weren't really studying that. If we were doing a rheumatoid arthritis study, the protocol would be very different and we would expect to see changes. But so it's not surprising that we didn't find changes in those 2 areas, but we
Yeah.
did in all the other areas.
Yes. Yeah. Social function, depression, anxiety, sleep disturbance. I really
And
like the
so-
social function matters a lot.
Yeah.
So
Yeah, because these people they're stuck in their houses. They're afraid to go places. They're afraid to go out because they have to be vigilant and they're scared and they're worried and they're fearful. And this seems to have taken all that away, for most of them. So I was most impressed, and I knew that you were studying this. I did the symptom checklist. I knew you were studying this, but I didn't know the results until I saw these data. And I was really impressed with the effect, what we call effect size, the amount of change and the number of people who were changed in terms of quality of life. And I think this
yeah. So
this is really
I got a message here. We need to wrap up. So
okay.
Well,
We do.
thank you both for attending today's webinar. It was I learned a lot more than I ever knew. So this was information to have. It feels like I'm back in college again. So it was great.
Well, there will be a test, Gail, so get ready. Don't go out and party this weekend. Study.
I'll be sure to study.
Our
Whoever
study days are
whoever wasn't able to attend today's webinar, don't worry, this is recorded. So we will have it on the Start Engine page in a couple days. I will add the link one more time into the chat box right here. Yeah, thank you so much, both you, Dr. Marshall and Marcus, and everyone who did attend today. Hope everyone has a great weekend.
I appreciate all your help and look
Thank
forward
you.
to seeing you. Okay.